Good morning, everyone.
Good morning, Sue.
Good morning, New. How are you?
I'm very well, thank you.
Good. Glad to hear it.
Good morning, Muriel.
Good morning.
All right, folks, I have 10 o'clock by my computer clock here. I know that the video live stream of this will start exactly at 10 o'clock. So just so folks know that we're about ready to start our meeting. Good morning, Kelly. And I'm going to ask Jamila to go ahead and continue to keep adding folks throughout this morning's meeting. Good morning again, everyone. Good to see so many faces this morning. Again, my name's New. I'm going to be facilitating today. We have a lot of work for us this morning. I want to encourage folks for the purpose of attendance. We're going to go ahead and ask that you place your pronouns in the chat. If you would like to be addressed in a different way, then please go ahead and put that within the chat as well. Your names are showing up as is on the screen right now. And so if you would like to be addressed in a different way, please include that in the chat. We'd love to see that. So go ahead and put your pronouns in there and we will collect all that as our attendance this morning. I'd like to welcome everyone here. We're going to ask and encourage folks for yes, George, you have a question? Yes.
My chat is disabled. I don't know if others are experiencing this.
I was going to say that
same
too.
for me.
Mine is as well.
Well, that's a good start.
Well,
we will get that corrected.
fixed it. Try again.
Try again. Thank you, Jamila. Thank you for saying something. Yeah. Okay, perfect. There we go. I see it coming through now. Thank you so much. Thanks for raising that point. So as far as today's agenda, we have a couple different things planned. We're going to go ahead and ask that for asking questions and raising comments, we were going to ask that you go ahead and put that within the chat. So if you have a question about something that comes up, please go ahead and put that in the chat. If you want to ask a question or be up next to ask the question in front of our colleagues here, go ahead and put in the chat next, and then that will help us kind of keep some type of order, so that I want to encourage everyone to ask their questions and then also be heard. And so I don't want to bypass anybody. So I really am hoping that that will be hopefully a more efficient way to get to all of your questions. I also want to note that because of the amount of information that we're giving you, I understand that there's going to be a lot of questions. And so for the sake of time too, I'm asking that you have some grace with me, that I would continue to move the conversation so we can get to the point today of offering a recommendation to the governor's office on who will be the next group that goes into the phasing sequence. Does that sound okay for folks? I would also ask that if you're not speaking, that you would turn off your mics, and that will help with better sound for all of us as well. Okay, so thank you so much. We're going to go ahead and, again, at the end of this meeting, we will have a recommendation to put forward as a group. We'll talk about how we get to that point through our consensus work as we get into discussion. We'll open it up for discussion after we get some more information and the data pieces. So with that, I'm going to go ahead and turn it over to Dr. Dean Seidlinger for our information for our presentation regarding COVID-19 data this morning. So Dr. Seidlinger.
Thank you. I assume Jamila might be driving slides.
I believe
Good
it's
morning,
Kristen.
everybody. Or Kristen's driving slides, okay. As long as I'm not driving. So I will go through these fairly quickly, and just because I can't see everyone's face while we're talking. And then if there are questions, try and take them at the end. And if pulling up the visual makes it at the end, we'll pull that up again. But I was going to give you a brief overview of COVID-19 and impact here in Oregon with some national perspective as well, focusing on some areas that people want to see around disproportionate impacts as we age and across different communities of color and our Native American neighbors. Next slide, please, Kristen. So we know that, and I think some of these are Dr. Sharif's slides, but I'll just keep going if we want to do it that way, unless Dr. Sharif feels ownership, we will switch back and forth. But we know that really from the start of this pandemic, that we've noticed some of our communities are at much greater risk for severe disease here in Oregon, as well as the rest of the country. Our communities of color, our tribal communities, older adults have suffered disproportionately from hospitalization and death. People with chronic conditions, and we'll go into this a little more, and people who are pregnant or breastfeeding also seem to have a higher rate of complications. Next slide, Kristen. Also, people with disabilities, including those with intellectual and developmental disabilities, those who are suffering from a substance use disorder or using other drugs, people living in rural communities, those experiencing houselessness, persons in correctional and detention facilities, newly resettled refugee populations, those living in nursing home and longer term care facilities, these congregate facilities, and then group homes for people with disabilities. As we look at racial and age disparities for COVID-19, this is just a broad summary, and I'll show you some more of the data on the next few slides. But by race and ethnicity, our Latino, Latinx population here in Oregon has really been disproportionately impacted by COVID-19, accounting for 13% of our population, but 37% of our cases of known ethnicity in our reports to date. So definitely over impacted by this disease. Next. We see similar hospitalization and death rates increase with age, with 3.9% of our Oregonians being 80 or older, but accounting for 52% of our associated deaths. And 77% of the deaths have been among Oregonians 70 years of age or higher. So COVID-19, like many other respiratory and other infectious diseases, does disproportionately impact people as they age, as we tend to accumulate other medical conditions, chronic conditions as we age. So, you know, these disproportionate impacts across race and ethnicity aren't due to kind of the genetics of this coronavirus. They're not due to the genetics of the individuals who are getting impacted. This is really a result of the structural racism and differential health outcomes that we came into this pandemic with. So the burden of health effects and deaths from COVID-19 are examples of how this racism affects or come from how this structural racism affects options in housing and employment among highly impacted communities. And many of the communities that are impacted, again, this is not a genetic basis, but these are individuals perhaps who are in lower wage jobs who continue to go to work and perform essential services, whether it is part of our food system, for everything from agriculture workers to food processing to grocery store workers, to some of our workers who continue to provide childcare for our youngest individuals in the state, who continue to provide healthcare for some of our older individuals and those with underlying conditions and chronic in congregate care settings. And so, you know, it's really these kind of structural bases that we went into that have impacted this. So next slide. We have several data visualization tools available on our website, healthoregon.org/coronavirus. We're going to go through some data that I pulled off those, but if anyone wants some additional help walking through those, you know, we're certainly happy to do that. Next slide. When we look at deaths by age, it likely isn't surprising to individuals on this call that we see deaths increase as age increases. So if we focus on the blue column, these are the number of individuals who died cumulatively since the start of this pandemic. And we see, like that summary statement stated, the vast majority of cases have been in those 80 or older. But if we look at those 50 and older is where we really start to see that increase in cases and see where you can actually see that blue bar. Our children and young adults have been much less impacted by the most serious aspects of this disease in Oregon, and that mirrors some trends across the country. Next slide. When we look at the same data across race and ethnicity, we see some similar patterns of differential impacts. Again, the blue numbers, that column represents Oregonians who tragically have died with COVID-19 or COVID-19 related deaths. The orange column are those who survived their bout with COVID-19. And then there's a total column to the right. As you can see, if we look at our white population, largest population in the state, they've had the largest number of deaths. But if we look at the rates, which are those numbers that are after the bar, a cumulative rate of disease, that rate is one of the lower rates in Oregon. Our Pacific Islander neighbors have been very disproportionately impacted, along with our Latinx population. Our Black, African American, and African population have also been impacted, as well as our Alaska Native American Indian neighbors. So, if we just look at absolute number of cases, we get a skewed view. But when we look at the cases compared to the total population in Oregon, we definitely do see those disproportionate impacts coming out. So next slide. Hospitalizations by age, again, similar to the fatalities, we see an increase as the age increases. Next slide. We also see a similar pattern of hospitalizations across different racial and ethnic groups. Again, if we focus just on the numbers, we lose sight of the fact of the smaller populations that are in some of our communities of colors and our Native American neighbors, and the truly disproportionate impact in serious disease that this has had across Oregon. Next slide. So we have, very similar characteristics nationally in terms of impact. And I think this table and the next table do kind of summarize some of the previous activity in a more kind of, in an easier form to get our heads around. When we look at hospitalization and deaths by age in comparison to 18 to 29-year-olds, so young adults, most of whom are healthy without significant underlying conditions as the comparison group, we see that children, both our youngest children as well as those school-age children, are much less likely to be hospitalized as well as die. But then as we increase in age from our 30s, our 40s into our older years, we see that hospitalization risk increases and risk of death increases as well. Next slide will show some similar data across racial and ethnic groups in this country with a comparison of relative risk compared to non-Hispanic white populations. That in terms of just absolute number of cases, we see that Native Americans across the United States, Alaska Natives, are almost 2 times as likely to have COVID-19, 4 times as likely to be hospitalized, and 2.5 times as likely to die. The next most impacted group in terms of number of cases are our Latino, Latinx population, again, 1.7 times as likely to have COVID-19, 4 times as likely to be hospitalized, and almost 3 times as likely to die. That number, that 2.8 number, is the same that we see in our Black, African American, and African immigrant population. And again, an almost 4 times rate of hospitalization and almost 1.5 times rate of being infected. So again, while it seems like the disease discriminates, it's really the structural factors that we came into this pandemic with that have allowed these growth inequities to occur here in Oregon and across the rest of the country. Next slide. I think with these, if Dr. Sharif is on, I'm going to pause and we'll see if we have some questions about those initial slides and then turn it over to Dr. Sharif for some additional comments.
Thank you, Dr. Seidlinger. I'll take a couple of the questions from the chat. There was a question, sorry, I'm trying to get to. Can you please explain to us how you will handle the 65 plus age group, how you will identify and implement vaccine location sites, and what data you will use? Thank you for that question, Sandy. Would you like to take that, Dr. Seidlinger, now or after the presentation?
I think we can take that after the presentation because I think we may talk a little bit more about some of the planning that's going in place right now for operations and where we might need some assistance.
Great. There was additional pieces on that regarding, are you working with the PSU Population Research Center? Dr. Duvivier also had the same question.
We use our population estimates from PSU to help calculate our rates when we are looking at rates either by age or race ethnicity here in Oregon. So those are the numbers we are using.
Great. I'll go ahead and turn it back over to both you and Dr. Shimi Sharif to continue. So if folks can, the questions specifically around 65 and over population, we will get to that as after this presentation. So hold on tight. Thanks.
Dr. Sharif, are you okay going on, or do you want me to continue?
No, I can do it. It's just a handful of slides left,
Okay.
actually.
Okay.
So just a little bit of background on high-risk medical conditions that actually pose risk for severe COVID-19 disease. So there are various conditions. I've grouped them here based on organ type, just to make it a little easier to digest. So cancer is one, all types, solid organ, as well as hematologic cancer, so cancers of the blood system. Weakened immune system, be it from solid organ transplant, bone marrow transplant, HIV, and the use of steroids or other medications that suppress your immune system from working. Kidney disease, including those on dialysis. Those with lung disease, this includes chronic obstructive lung disease, including emphysema, asthma, especially in higher stages of disease, so moderate to severe asthma requiring at least one controlling medication. Pulmonary fibrosis, which is as a result of scarred lung tissues, as well as cystic fibrosis. Next slide. Developmental and neurologic diseases. So this relates to illnesses that are a result of development in the womb. So including Down syndrome, neurologic conditions such as dementia, and people with strokes and other cerebrovascular disease, so disease of the arteries and vessels of the brain. Heart disease, including those with heart failure, heart vessel or muscle disease, so that's anybody who's had a heart attack and survived or needed to have angioplasties or stents placed, as well as those people who recovered from viral diseases of the heart muscle and then recovered, and those with high blood pressure. Liver disease of all types, including from hepatitis and other liver disorders. Blood disorders, including sickle cell disease, and another subtype of disease is called thalassemia. Next slide. Diabetes, both types 1 and 2. Smoking, people who are overweight, defined as those with a BMI of greater than 25 kilograms per meter squared, but less than 30. And then obesity and severe obesity, which are at cutoffs of BMI greater than 30 or 40, respectively. And then those who are pregnant. Next slide. In addition to this, there are workplaces and certain settings that are at high risk for transmission. So a few of those include hospitals and outpatient healthcare facilities, which actually determined the priority groupings in 1A. Correctional facilities, prisons, jail, juvenile detention centers. The staff of these correctional facilities were already included in 1A. Food processing. Next slide. Agriculture and nurseries. These can include, nurseries where produce and other agriculture is harvested and people work in close proximity to each other. Manufacturing and warehousing facilities, again, in large factory settings with workers working close to each other. Construction, waste management, and transportation. Next slide. That's it. And I think we have some additional questions now in the chat box.
Yes. Let me get to the top of them. So additional
I'm trying to
questions.
answer a few as we go along. So.
Great. The question, do we want to go ahead and try to answer some of the questions around 65 and plus right now? Or do we want to go into some of the questions specific to this presentation? Let's hold on the 65 plus for a second and then get more specific to the questions based on the slides by our health advisors here. Question from Daisy. Can you all share how you are collecting this data? Are you asking patients to identify when they are being tested or if they go to the hospital?
Yes, I can speak a little bit about this. So we are asking for all those people who are tested. Oh, go ahead, Dean.
No, I was just going to say I put that answer in the chat as well, but I think Timmy's
okay.
going to kind of.
Oh, yeah. So I was just going to talk a little bit about REAL-D data collection. So there's a requirement that any person identified as a COVID-19 case, as in they've been tested and tested positive, race, ethnicity, language, and disability data has to be reported. And this is a mandatory requirement. And the same thing happens for those who are hospitalized as a result of COVID-19 disease.
I think there might be a question we skipped over from Sering.
Yeah, Saring's question, again, Leanne, was about the 65 and over group. And I think Dean determined it might be helpful when we get to that operational considerations we already have, potentially to get to that question after.
I think it's also, I'm seeing a distinction around underlying conditions too in that question.
Oh yeah, her question is basically underlying conditions to be included along with teachers age 65. I did not read that in the governor's letter, so asking directly for more insight. So my response would be the federal government did propose expanding all groups to 65 and over and those with high-risk medical conditions. The focus in Oregon is because we're doing a collaboratory approach to prioritizing these groups. We've decided that 65 and over would be considered a priority group, but other groupings would be determined based on co-creation with the VAC.
Next question from Dolores is for high risk, all the categories are on this slide.
Yes, this is the most inclusive list that I was able to find. I did see that Safina pointed out later that renal disease, meaning kidney disease, is not considered a high-risk medical condition on the CDC list. So the CDC has two groups of conditions, one that are classified as at high risk for COVID-19 disease and another section that says maybe at risk for COVID-19 disease. I've included the most inclusive of the two lists, so I've collapsed the two into 20 plus disease states.
Then Dr. Doldelau, if you look at the breakdown of many of these medical conditions, we see a lot of disproportionality by race and ethnicity. It's important to see the intersection.
Yes, so that's kind of why we prefaced that some of the data that we're going to present, even though we're looking at high-risk medical conditions, they're extremely correlated with structural racism and the impacts it has by different racial groups.
And I'm going to go ahead and read the response for Daisy's question by Dr. Seidlinger. For individuals who are identified as cases, demographic information is collected as part of the public health investigation. So for those hospitalized, if we do not have the information from the investigation, it's collected from hospital records. Question from Zenya. Are those listed in the order of risks, or are they in an arbitrary order?
They're just in an order based on organ system. They're not necessarily categorized saying like one condition confers more risk than the other, because some of this data is actually still ongoing and we don't have a clear sense of which conditions pose more risk than others.
Thank you. And then another response for Dolores. These slides include the underlying conditions identified by the CDC. Dr. Qureshi, also renal disease has been shown to be a high-risk medical condition and isn't on the CDC list.
Right, so the CDC list, when you break it down into two groups, renal disease is not on the primary list that the CDC begins with, but it is on the secondary, hence the reason to make a more inclusive list.
And as a response to Dr. Dildalau, yes, there are health inequities that people came into the pandemic with. Charity, in light of the mandate from Oregon Governor Brown to include people at 65 and older and educators, what exactly is this group being asked to prioritize? Thank you for that question, Charity, and please.
Hi, so I can speak to that. I think where we're at, there's a couple of things that we need to do now. So generally speaking, I think we have, a couple of groups identified. So we have group 1A, all of the folks in there. I just largely would say that's group 1. We have group 2, which is folks in the 1B, which we know are educators and 65 and up. Now we need to determine, and then at the end of the line, we know we have general population. So I think this group, this vaccine advisory committee, it would be really great today to determine, are there additional steps between what we have already prioritized in Oregon and when we get to general population? I would just say in terms of operationalizing that, we'll need to kind of have a conversation, and then it would be great to allow us at OHA to go back and work with partners to think through how would we operationalize that, and then come back and have a conversation. But if this group can help us today determine, based on what we already have prioritized, 1A, and the two groups already in 1B, what additional folks do we need to be thinking about before we get to general population vaccination?
Thank you, Rachel. I think that there were some suggestions around the VAC taking a look at Washington's proposed phasing as a starting point, and then looking at, I believe that was raised. So does that work for folks? Understanding of what we're asked to be prioritizing today, coming out of today's meeting, we will make recommendations on the next group of folks for sequencing.
Hi, New. This is Marin. I have a comment or a question, I guess, or a recommendation. I guess knowing that diverse communities have been impacted very highly with COVID, and specifically Latinx and other people of color, I recommend that with educators, that along with that group, that agricultural food processing workers, which are essential, be part of that group. I really do believe that. I think considering the risk, the spread, the allocation in terms of the feds want us to push forward, again, from a distribution standpoint, I know it'll be a challenge, but I do believe that those workers, that workforce, cannot wait longer than that. So I would recommend highly agricultural workers, food processing workers, environmental services workers in that arena, from an equity and essential workforce standpoint, to be part as educators within that guideline. Again, that's my recommendation.
Okay, thank you, Marin. do folks at this point, I want to give folks, I know that there's still, from my list, it looks like there's about 17 more questions or comments in the chat. And we also have a recommendation right now from Marin to include food processors and agricultural food workers to be part of the next group. How would you like to proceed with this conversation as it is right now? Do we want to continue to look through the chat for questions and have folks, OHA staff, answer them, or do we want to dive into talking about the next group that we believe the recommendation for the phases?
I would like to dive in and have the questions either answered via email, because we only have about 2 hours, and I really would like to see us walk away with a product beneficial to the community, and then OHA answer each of these questions by email and send it out to all of us so we can stay on track.
Okay, thank you for that, Christine.
Mm-hmm.
Can I hear from a couple other folks?
Yeah.
Yes. Sean?
Yeah, I think we should proceed to discuss around a recommendation. You know, I think Marin makes a great point. We could certainly look at the Washington stuff, but the data that was provided in the slide deck clearly indicate a couple of priority groups that could be moved forward today in a recommendation that would both in my mind, you know, if you pick the top 3 or 4 of those occupational risk categories, they also dovetail with a lot of the inequity that is present in the healthcare system. And we could address both of those things with a recommendation in line with the one that Marin brought forward, which I believe also lines up pretty well with the Washington algorithm that's out there.
Yes. And I agree with that.
Mm-hmm.
So I'm seeing a lot of head nodding like this, and so I'm
Sue?
yes, please.
Leanne, I see that someone has said, Leslie Sutton has said, I have a comment. I just want to make sure that comment might be pertinent to this conversation right now.
Yes,
So,
please.
Yeah, thank you.
Leslie?
Thank you, Leanne. I appreciate the conversation about looking at who we prioritize next. What I would really like to see is an assurance from the Oregon Health Authority that they will actually implement the phasing the way that has already been set up, and also the way that this group says needs to happen. Because if that doesn't happen, you will end up with empty promises to groups, and that is exactly what the developmental disability population is facing today. OHA has still not properly messaged out to healthcare providers, vaccine clinics, and local health authorities that people in the developmental disability world, including no matter where they live and their workers, are part of phase 1A. And what I see from this committee and these members is hope that we can make things different, hope that we can get this vaccine to the right people. And what I can tell you is there is a promise that is being broken every single day in Oregon when people with developmental disabilities are not getting the access to the vaccine that they are due today. And I just want to make sure that we have, moving forward, a commitment from the Oregon Health Authority that when this vaccine advisory committee acts and says who is in the next phases, that you will implement this with partners in a way that makes that real. Because otherwise, we are providing empty hope to people that need it most. And that is not fair, it is not equitable, and it is not right. So I just want to make that very clear that I would really like to see a commitment to do this right. And it's very difficult to sit in a seat making this kind of decision, knowing that at the other end, there hasn't been a commitment to make this right now. So I'll leave it at that. Thank you.
Leslie, as a vaccine provider, I did get information from OHA that group is in phase 1A, and I'm sorry that other vaccine providers aren't honoring that. And that's too bad, because the information is out there, and we've certainly included that population here. So I think in the chat, I've also seen this kind of question repeated that maybe might be helpful to answer is, how many vaccines does Oregon have? Like, are we prioritizing more groups than can be immunized? And maybe kind of understanding how the vaccine's going to be pushed out, you know, and maybe knowing that number in regards to the number of people we're saying are a priority, so we don't end up giving empty promises, you know. So we are saying that we're going to prioritize a group and then there's not enough vaccine for it. So can we talk about that a little bit too?
And if I could add to that,
Yes.
I agree with Maren about we have a lot of hourly workers. We know who they are, who can't do their jobs from their dining room tables on Zoom, and we have to make sure that they are safe. And it's a lot of folks who we have seen have been disproportionately impacted, and we do have to think about those folks soon. But the operational side of this, which Leslie and others have defined, is really important. We need to know how the state is citing the vaccination sites, what the plans are for moving people through, because that's going to impact how we reach those populations. I thought the fairground site was terrific, but we have a lot of Latinx community members who are not going to go to a site that has the National Guard delivering the vaccine. And we know neighborhoods, and that's why I asked about the Portland State Population Research Center. I was on the phone today with the president of Portland State, who said, we can help. Nobody has called us. They know where all of these populations that we're trying to reach are. So with the 65 and older group, how are we determining where those people live, where low-income people over 65 live, where the Latinx community? I mean, just we need to understand that and know how the state is operationalizing this. Otherwise, the prioritization, frankly, is going to become so complex, we're not going to be able to administer it.
Thank you, Sandy. I want to address a couple of things that have been brought up just now. So back to Leslie's point about the commitment from OHA. Can we start with that? Would OHA folks want to address that piece and restate the commitment to the recommendation coming out of the VAC would go to the governor's office and being implemented? Would somebody want to speak to that?
This is Rachel, and I can speak to that and welcome other folks. And I, Leslie, appreciate the comment, and I can tell you it's something that we have conversations about every day, every meeting, is how to ensure that our focus and the intent of the policy that we put forward in terms of 1A, which is more expansive than many other states, which intentionally does include, like you talked about, folks with intellectual and developmental disabilities and their caregivers, that we can operationalize that, and having conversations with local public health authorities. I want to acknowledge absolutely that those communications have not penetrated, if you will, throughout the vaccine distribution system. And we know that we have more work to do there. So we've communicated a couple of times with local public health authorities. We're working with the vaccination sites to make sure that there are, and counties to make sure, particularly before people want to move to the next phase, that we're having conversations about how have you reached out to, group homes? How have you been working with folks? What have the communications been like? And furthermore, as we move throughout the vaccination process, we will be continuing to have conversations. We know that, let's just say that once it gets to another phase, if there still may be people from 1A who still need to get vaccinated, and we want to see those people prioritized, operationally, that could look a variety of different ways. It could look at holding certain hours or having a fast track line. I think those are some of the conversations that are still to come. But I want to say, point well taken. We definitely want to see that the people that we prioritized in 1A for equity reasons, for policy reasons, on the ground are able to get that. We know that that has fallen short. We know that we've heard that people were turned away. And we are actively working with the organizers of these events to ensure that people aren't turned away, to ensure that people know that they're eligible to get vaccinated and are able to get vaccinated. And then whereby we need to have plans where mass vaccination sites and other things are not going to work, then we're going to continue to work on that. So to restate the commitment, absolutely. To acknowledge the problem, absolutely. And to say that we're going to keep working on it, absolutely, and look forward to partnership in that.
Thank you, Rachel. Part of the next piece was there was comment from both Sandy and Charity regarding operational side. Is that a piece, we know that, yes, there's the piece of sequencing and giving that recommendation forward, but we also know that the operational piece is just as important, and how are we getting through that? Is that a piece that we can address and offer folks at Tuesday's additional session to get you some of the information about how some of the operational pieces are being handled? Is that an option? I'm being conscientious of today. The recommendation that we want to put forward is about sequencing and who is in that next group. So is that something that we can put to Tuesday's information session about offering you more information about how OHA is handling that piece?
So this is Muriel. The only thing I'd like to add to it quickly, and it's a really quick operational piece, and I can say it really quickly, is that as far as from the local standpoint, I mean, we have created checklists and I'm actually personally, my staff are giving shots. I'm actually personally going through the list, reaching out, finding people throughout the state who kind of oversee or calling DHS and finding those groups. So from an operational standpoint, that's sort of how we're doing at the local level. So in our case, not only are we reaching out and trying to provide vaccinations in Crook County, but I want to thank St. Charles. St. Charles has actually posted on their website, people that are in the 1A group, click this, sign up, and St. Charles is offering throughout the Tri-County area, anybody in 1A. So I think the bigger challenge we've had is figuring out who do I need to reach out to find this group of individuals. And I've pretty much done it, but it has been, from an operational side, that has been a little bit challenging. But I just want to assure the group from a local level, we are really working through that list as hard as we can and trying to find all those individuals and offering them the opportunity to get the vaccine.
Yeah.
Thank you, Muriel.
I think that, this is Maria, I think one of the things that as a group, I would like to see our sequences and try to get something today, at least so that we can show that we want this to happen.
Yes.
And the other information, if we want more information about distribution, we could do it on Tuesday. We know that there are delays by the federal government. We know that there are delays for the vaccine to get to us because we haven't gotten it. I mean, we only got a small amount and we're working on that, but we're doing the same thing. We're doing the local stuff. We're working with the counties. We're working with the hospitals to find the people in the group. So I think all of us that we work in the health field are trying to reach the people that we think we know need it. So I think we need to trust that and hope that the local people get the support from the state so that we can get the vaccines distributed. And that's the main thing. We want to get those vaccines distributed. So if we can do that and prioritize, that's going to help our population the best. Thank you.
Okay, thank you, everyone. I know that within the chat, there's a lot of questions and comments. And so if it's all right with you, if we can pull up the Washington State phasing graphic. I believe I have that. Or do you have that, Jamila? I can pull that up.
You probably have it faster than me, but I can look for it.
Oh, Kara has it.
Kara.
Okay, thank you, Kara. So, and based what I'm hearing from the group, we want to go ahead and continue this conversation and give people an opportunity to see this. So this is the Washington COVID-19 vaccine phasing piece. I believe some of you may have seen this already, some of you may have not. would any of our health advisors be able to walk us through this piece and share where Oregon and Washington differ?
I'm not sure if it's just
Can-
me.
Oh, sorry. Yeah, I was trying to.
only see a corner of the document. I don't know if that's my screen or if other people are having a similar situation.
Kara, maybe can we collapse the window a little bit? Maybe it's going outside the screen for some folks when it's full screen. Just up top, yeah. Is that better for people?
It's still really zoomed in for me. Sorry.
Okay, let's try.
This is Kristen. I wanted to acknowledge that Kristen Milligan put in the chat a link to the document. So if you're able to view it on your own browser, that's also a possibility.
This is Kelly. I would just like, when we're looking at these slides, if whoever's presenting could be really clear where equity is being followed or represented in those slides, in those plans that, like this Washington's COVID-19 vaccine. If someone presenting this could also be really clear where equity is being centered.
Yeah, sure. I can point them out specifically. So Washington State names their phases a little bit differently than the ACIP model, but as you can see, A1 and A2 of the Washington State system corresponds most closely to ACIP's 1A. So this includes high-risk healthcare workers in healthcare settings, high-risk first responders, similar to how Oregon has done it by getting people working in fire and other first responders in this group, long-term care facility residents, and Oregon has actually expanded that to other congregate settings, including for behavioral health as well as for developmental disabilities. All other workers at high risk in healthcare settings. So that includes people working in outpatient settings, community health workers working with the public, especially for testing events, et cetera. When you go to B1,
Jimmy, can I just point out one thing to kind of Kelly's point, if I could just jump in with Oregon, where we've done in our 1A, where equity comes in is that we have healthcare interpreters, we have traditional healthcare workers, we have anybody who's working in a healthcare setting, including if you're serving food or cleaning rooms or doing something else behind the scenes. So those are some of and we have those folks who have intellectual or developmental disabilities, or those people where someone's coming into their home. So the home isn't, in other places, isn't considered a healthcare setting, but for us, because that setting, there's healthcare workers coming in and there may not be the ability to control the risk in that setting. Those are all of the things that we added to this sort of a framework in Oregon for equity.
Thanks, Rachel. Moving into phase B1, which Washington State anticipated starting in January of 2021. This includes people over 70 years or older. So this is a slightly lower threshold than the traditional ACIP recommendation, which is for 75 and over. And this is really just to capture more people at earlier vaccination times, as well as all people over the age of 50 or over who live in multi-generational households, which are homes where individuals from 2 or more generations reside together, such as an elder and a grandchild. I would focus this as an equity-focused differentiation for Washington State's plan as opposed to the federal recommendation, because we do know that people who live in multi-generation households, this is extremely correlated with different racial groups that have been highly impacted during the pandemic. And so the focus on 50-year-olds who still are in the workforce, and especially in essential work capacities, are at higher risk for disease, as well as for worse outcomes due to COVID-19 as a result of their age, as well as the correlation of age and the risk for having 1 or 2 high-risk medical conditions. Moving on to B2. B2 includes high-risk critical workers 50 or over who work in certain congregate settings, including in agriculture, food processing, grocery stores, K-12 educators and staff, childcare, corrections, prisons, jails, or detention centers, public transit, fire, and law enforcement. So a little bit of a correlation how B2 for the Washington state plan is equity focused is because, again, they pick people over 50 years of age or older and who work specifically in high risk situations and environments such as in congregate settings and in a lot of the workplaces that have been shown to have higher rates of outbreak and transmission and therefore exposure to illness and therefore possibility of like severe outcomes from COVID-19 disease. A little bit of a relation to how this relates to Oregon's planning so far. Oregon's educators and staff have already been outlined as a priority group for phase 1B, outside of the decisions made from the VAC. And also those workers who work in corrections have already been prioritized within 1A, as has people working in jails, detention centers, and also in some first responder capacities, such as for fire and law enforcement, I believe. Somebody correct me if that's wrong. The groups that remain are the ones in the Washington group. So like agricultural, food processing, grocery stores have not been prioritized yet. Yeah. Questions before I proceed?
Yeah, I have a, oh, sorry, go ahead.
Thank you, George. You know, I had a question in terms of currently within the state of Oregon, what is the distribution plan right now as it is right now? Is there a plan? You know, is that going to change, or what is, I guess from a committee standpoint, I want to understand more exactly what you're doing overall statewide in terms of distribution of the vaccine, in terms of working with counties, regions, health providers. Is there like a master plan, or there's just as we go along week by week, or it changes day by day?
I think, Rachel, you might be closer to some of these discussions, especially with the changes happening with the federal announcement.
Yeah, we do have kind of overall a big plan that has various work streams. There's hospitals, there's FQHCs, there's, you know, LPHAs. And I wonder if that's something that we can also kind of think about bringing on Tuesday, so that folks can really ground, like thinking about these policy decisions, how would they actually get implemented? And my hope is that if we can get through today, kind of what's the what we want to get to, and then really come back next week a couple times, both on Tuesday with the groundwork and Thursday having a conversation with this committee of what are the things based on everything that we've learned that we need to make sure are incorporated in those plans, so that the policy intent carries out through implementation.
I have a comment to make about this this slide, and this follows a lot with what Kelly was saying. Is this slide doesn't explicitly call out BIPOC communities, and I'm very concerned about this and the way this conversation is moving. There are categories, for instance, if you look at B3, comorbidities on underlying conditions. There's no mention about BIPOC communities. And if you just use a broad category of comorbidities, it's not centering equity, because we know that given different comorbidities, we still have poor outcomes given for BIPOC communities. So, I mean, we started the conversation here with slides showing the disproportionate outcome of BIPOC communities with comorbidities, whether it's diabetes, hypertension, and this doesn't recognize this. And so using these broad categories without explicitly prioritizing BIPOC communities risks diluting effort and causing harm in the BIPOC communities.
I would also build on that. I'm sorry, I'm just stepping in here. Thank you, Dr. DeVivier. I would also like to ask, you know, how is this, I guess what I'm concerned about and not seeing is an anti-racist, anti-colonial framework that we're using. And when we are not, when we are being asked to center equity you know, being shown data with the disproportionate impacts among our Black and Brown communities, you know, that's what I was asking. Where is that being centered here? I don't see that specifically being centered, and I want to make sure that we aren't effectively using racist approaches and using a language that makes us appear and seem as if we are not actually, that we are using liberatory approaches or equity approaches. I think that's what I'm asking for. Where are we using an anti-racist approach in the sequencing and understanding these groups, these priority groups?
I think this might actually be a good time to talk about the recommendations that the Oregon Pacific Islander Coalition, and finally hearing from Dr. Raphael, this might be a good time to segue to those if possible. New?
I am trying to figure out if we can kind of backtrack. I know there's been hands raised by George, Dr. Raphael. I know that there have been some comments in the chat. I am a little bit at a loss right now, trying to think about being respectful to giving you all an opportunity to ask your questions and comments. And so if it's all right, I'm going to ask that we go with a little more order with Dr. George Conway, Dr. Raphael, and then Dr. Doldalau, if that works. And then what I'd also like, I've been reminded that we need to take a quick break as well. So does that work for everybody? Perhaps we take the break now and then we go back, and then I will run down a list of who will have the floor next, if that's okay with folks. And then I will try to get back to this. I'll review the chat and see where we are with folks, because I'm not trying to ignore the chat. It's just a lot of information that we all want to give people space to state what they need to state. So I'd like for us to take a 10-minute break, if that works, and then we will reconvene.
New?
Yes.
May I project, if we're going to talk about a letter at some point, it wasn't included in the public meeting packet. May I share my screen while we're on break with the letter up?
Yes, I believe that's fine. Thank you.
New, I know you said coming back, you named 3 different doctors, but Daisy has had her hand up before all 3 of those doctors, and she has not been acknowledged at all. I think she should be the first person.
Thank you. Thank you.
Yeah.
New, how long is the break?
It's 10 minutes. So we'll reconvene at 11, are we doing 11:05 New or 11:08? Sorry, the question New was how long is the break? Are we convening at 11:05 or 11:08? You're on mute.
Sorry. 11:05.
Okay.
Thank you.
Greetings to anyone who is just joining us. We are on a short break and we will reconvene at 11:05. Currently on the screen, I'm showing a visual of a letter submitted by the Oregon Pacific Islander Coalition. Hello to anyone who is just joining us. This is the Oregon COVID-19 Vaccine Advisory Committee. We are currently on break and we will restart the meeting at 11:05. I am showing on my screen a letter from the Oregon Pacific Islander Coalition. This was referenced by a committee member.
Okay, welcome back, everyone. I'm going to pull the group back together. Again, thank you for your patience with this process. We know that we want to ensure that folks get the opportunity to be heard. So in my notes here, I want to, one, let folks recognize that the Washington example is just that, an example for us to see how another state is doing it. That is not necessarily a recommendation of a starting point. It is an example. And so I just want to throw that out there. As far as how we want to proceed for the rest of the time that we have so that we can get to a recommendation, I would like to ask one that Daisy, you will ask your question next, then we'll have George, then Raphael, and then Dr. Duldalau. So those are the folks. And then Kristen, I also have you down as well. And I know, and I apologize that we're very much out of a sequence today, given the chat idea. And so asking for forgiveness right now. And so we can proceed, and then we will get to folks as we go along. So that's kind of where we're at. Daisy, George, Raphael, Dr. Duldalau, and then Kristen. And then from then we have something that OHA has put together, kind of showing the next potential groupings, or who's left to be part of the next group of recommendations. So if we can go ahead and move forward. Daisy?
Thank you. Yeah, I just, my main question has been, I'm really curious about the outreach and distribution that OHA is doing right now. Leslie raised some concerns, but I'm also curious, and I wouldn't feel comfortable making a recommendation without knowing what the distribution or outreach is going to look like. And specifically for folks who speak Indigenous languages, what are
you have a paper, or are you getting a link?
Are you all working with CBOs? How is that going to work? I know that Sandra also mentioned the fact that, you know, folks might not feel comfortable going to the National Guard or getting a vaccine with that. So that's, I guess, a two-part question. And then lastly, I'm very curious about the data collection going forward. Is this going to be protected only by the state? We know that Oregon has a lot of undocumented folks who also follow under the farm working population and agriculture. So I'm really wondering about all of that.
Thank you for your questions, Daisy. Do some of our OHA folks can address a couple of those pieces? I would say that some of the distribution pieces that we had talked about earlier today, we'd like to try to address some more of the specifics on that on Tuesday's session. So for folks.
Try to chime quickly.
Go ahead.
Sorry, just acknowledging that we'll come back and provide more information on Tuesday. Daisy, I really appreciate your questions and folks' understanding of how, you know, policy and operations go together to ultimately ensure that we're on the ground getting the outcomes that we want to get in terms of policy conversations. I think that's really important. So right now our operations are in a number of kind of tracks. We have operations that are going through tribal health programs and tribal communities, and so tribes are determining what that looks like and who's in the priority populations. We have hospital levels distribution, and folks may have heard that right now there's a really big push on getting a lot of vaccines out, so these high throughput locations. Folks may have heard about, like, working with there's a distribution site at the Salem Fairgrounds. We're working with counties, as Muriel talked about, counties across the state are working with their communities. I think the language access is huge, and I would love to be able to come back on Tuesday and for us to talk about where are different sites and what the language capacity is there. Yes, we're working with community-based organizations, and Kara's team is doing that. And we also have a long way to go in terms of getting enough vaccine in Oregon that we can have vaccine distributed at all of the different types of places that people actually want to go. Because to your point, we know that the National Guard is threatening for people, that mass vaccination sites may not have the accessibility for certain communities, and all of those things. So that's where we are in the first round of pushing out vaccines. And we're working, and vaccines are throughout counties who are working with CBOs as well. And our next iteration is really to make sure that we have enough distribution sites and the right culturally appropriate distribution sites to make sure that we're hitting all those marks.
Thank you, Rachel. George?
Yes, good morning. I'll try to keep this very brief. I think this is consistent with Derek Duvivier's comments, Marin Uriel, as well as the Pacific Islander proposal about structural racism. And I think it's really important that we not miss. And I also agree with Marin's mention of agricultural workers and food processors. I think those are really important to attend to. I just want to be sure that we don't miss one of the most obvious and egregious structural racism, which is those that are incarcerated. So I just want to, and I noticed, one of the reasons I bring it up is that the workers in those facilities were the second tier in the Washington thing, but the people that are resident in such facilities are the fourth tier. And I really would encourage people to consider, because they're people that they can't go out and do anything about their circumstance. And there have been very, very high rates of outbreaks in them. And I'm talking specifically about prisons, probably more than jails. Thanks.
Thank you, George. Dr. Raphael?
Hi, just speaking on behalf of OPIC, but also as a physician. When I looked at these priorities, it's driven on occupation, which I think is important. But as a physician, the people that I'm seeing are the older people. So I completely agree with prioritizing them at this point. But in addition to older individuals, the people that I'm seeing in the hospital come from minority communities. This is Oregon. This was when I was back in Utah, and you've really shown us the data, and I think we should follow the data. And I think this is where our recommendation is coming from, is that we know the data, we see the data, we should acknowledge the data, and we should prioritize communities that are disproportionately affected. If that's based off of race, or for example, the Slavic community, right? We should prioritize those individuals. And so we would like to formally recommend that those communities be prioritized, with the current group being those people who are older than 65, as well as the teachers. Those folks who are being prioritized now, we would like to propose that.
Okay, thank you. Noted. Kristen, excuse me, Dr. Doldelau, and then Kristen.
Thanks. I just want to add that, I'm looking at the chat and looking at a lot of the references to the impact of race and racism on health. So when we look at race in health, that is a proxy for structural racism. That is not a proxy for anything else. We look at it, it's not a proxy for culture. It's not a proxy for genetics. It is a proxy for structural racism. And we are looking at the Oregon Pacific Islander Coalition is emphasizing Black, Indigenous people of color, because those are the people most impacted by structural racism. We know that, by emphasizing on occupations, it's true that we see racial stratification in occupations, but we know that structural racism impacts the lives of BIPOC people holistically. It's not only in your employment, so Latinx folks being, marginalized to agricultural work or public facing work. We see that in Pacific Islander community. It's also insurance. Who's covered by health insurance? Who has access to healthcare? Who has the patient-provider relationship? Who experiences racism in that relationship? We saw a doctor, Dr. Moore, a Black doctor who expressed, not in Oregon, but expressed the racism that she experienced being treated for COVID, even though she's a physician, right? And she ended up passing away from COVID. We also see it in educational access, and we also see it in employment, right? And so, BIPOC are overrepresented in public-facing low-wage jobs. And that's not my opinion. That's research, that's science, that's evidence. And these, the high rates of infection, hospitalization, and death among BIPOC people is not just in Oregon, it's across the nation. So this is a national trend. And when we only focus on these so-called life circumstances, we do not acknowledge how structural racism shapes those life circumstances. And, you know, there are a lot of people that work low wage jobs, but not all of those people are impacted and put into those jobs because of structural racism. And that's why we're emphasizing BIPOC communities, because the impact is multifactorial. And we know as the Oregon Pacific Islander Coalition, as BIPOC people, how this works, right? BIPOC people were prioritized for testing. So I don't understand why they cannot be prioritized for vaccines. They were explicitly prioritized for testing based on the data. So to not extend that to vaccines does not make sense. It is not evidence-based. It is not based on the data. Thanks.
Thank you, Dr. Dildelau. Sorry, Kristen, did you have something you wanted to also ask or share?
Yeah, I have a question regarding sequencing and whether or not this committee has the ability to make the decision on whether or not prisoners are going to be included in the next phase, because last meeting it was discussed that the governor had already said that that would be the case. However, the information that's provided on the OHA website says that it's in this group's purview. So I need clarity on that.
Great, thank you, Kristen, for that. And we're going to turn that piece over to OHA staff to address what specifically, which groups specifically are already accounted for in this next phase, and then which groups can this the VAC put forward as a recommendation.
This is Leanne Johnson. I'm just wanting to take one step back if we could and discuss what, so there are several recommendations on the table, including the letter. And we just heard some very heartfelt, very true information with a deep, meaningful plea that went with that. I don't want us to skip over that and at least acknowledge in the room when will we have the conversation that OPIC is asking us to have and other members of this committee are asking us to have.
Can we at least name the recommendations? There's so many recommendations and so many people talking. I've lost track of even what's going on. There's no clear path of anything, and we only have 40 minutes left.
There has been a recommendation put forward to this group that there would be an inclusion in the next group of folks after educators 65 plus and over, that has been stated. That's not something that the VAC will need to agree to or anything. That's been stated and that's moving forward, right? So my understanding is that this group would bring forward recommendations for which groups of folks next to be sequenced. And that could be as simple a recommendation as the VAC recommends for, and this is just an example, the VAC recommends that food processors, agricultural food workers, and BIPOC communities be considered in the next group. So that would be an example. So this is where the breakdown of, we can recommend group by group groups in that regard. So even if we came out today with the VAC recommends food processors are in the next phase of sequencing for vaccination in Oregon. Is that correct?
To be included in 1B, or to be put after 1B, and 1B is just people over 65 and educators?
The recommendation is with 65 and older, as well as educators.
Yes,
that's the recommendation.
So to be included in 1B.
Yes.
Is that correct, Rachel? I just want to confirm that that's the recommendation. That would be what we're asking of this group, the VAC.
So do we not need to know how many vaccines we will have in order to answer that question? Do we have enough to cover educators and 65 plus, and how much is left over?
I don't think we still know how much. I don't think that we need, I think we need to make the recommendation and decide these are the groups when the vaccines get here.
Yes.
Because if we try to figure out how many vaccines and who's going to get it first, that's going to take forever. That's not our job. Our job is just to recommend the groups and then and allow the state to get the vaccines when they get them.
Yes. Yes, Maria, that is correct. So go ahead, Sean.
Oh, would this be a good time to just put a specific motion on the table so we have one recommendation specific that we are going to debate and alter or modify?
Yes.
Yeah, I think that would be helpful. And I wonder I'm not sure, Kristen, with what's coming up on this slide, but if there's information on the slide that pertains to the conversation, that would be great. Otherwise, I'd suggest that someone from our team just puts up a screen where they can take notes and we can list all of the different recommendations.
Yes.
We can list off some of the things that I've heard.
Yes.
To the question of sequencing, what we know so far is we're in 1A right now. Let's just largely say group 1. Group 2 has been identified as those over 65 and those that are working in the education, early learning, childcare groups. I think it's most helpful for this group to say, these are the priority kind of groups, populations in all of the ways that you've talked about them. And then we can have conversation about where do they come in the order. I'm willing to have a conversation with leadership about, do we add more people to 1B? Do we say those are the next people going and whatever? But I think if this group can come to like, these are the folks and the principles for the next grouping, then operationally we can take that back and say, how might we operationalize this? And I really agree with the point about shortly, there's not enough vaccines. It'll take a long time, as Maria said, to match those up. So I think the best thing is really to move forward in terms of the priority populations, and then we'll march through as we have vaccines available, excuse me.
So there was a question about the remaining groups for discussion, and this particular slide that's been put up is stating that individuals not already covered in previous groups include adults 16 to 64 with chronic conditions, adults and youth eligible for vaccine in custody, and then frontline workers. And the definition of frontline workers has not been established completely.
I would also like to see this group consider prioritizing people with, say, organ transplants, chronically immunosuppressed. Again, the current structure of this list is kind of occupation driven, but doesn't really kind of address the people who are most severely affected or potentially affected from a medical standpoint. So I would like us to consider elevating these people with chronic conditions into a higher level, because they're the ones calling offices and saying, I have a kidney transplant, when can I get my vaccine, for example.
I'd also like to interject. Rachel, this is responding to something you had mentioned earlier about priority groups in the first sequencing. I still haven't heard specifically how urban natives are being included. I've heard, you know, a clear plan and approach so far for tribal communities, but not our urban native community. And one, I think that needs to be distinguished. And two, I think that it needs to be acknowledged. And if we don't, then we are perpetuating systemic violence against Native people through the active participation of invisibilizing our people. So I also heard in the recommendation in the discussion, the need for an anti-racist framework and to acknowledge and be very clear when we are upholding status quo and when we are going beyond that, and to name that so that then as we move forward, whether or not it's in this group or beyond this group, we are continuing to build building blocks for that transformation of racial equity that we are calling for, and that the Oregon Health Authority is committed to within its 10-year strategic plan. Finally, I just want to also uplift again, because I see it being buried, is public health is acknowledging that racism is a public health crisis. And so if we are not also including racism as a determinant of health, then how are we going to include that in our decision-making and our policies and our practice? And if we need broader education around that and to understand the evidence and the rigorous body of science that is available to us, then maybe that's something we should be considering as well. And perhaps that can happen on our Tuesday calls. And I'm happy to contribute, as that is the body of research that I have helped to establish, specifically the impacts of racism on the health of Native people. Thank you.
Thank you, Kelly. I have a couple of motions on the floor that I want to go ahead and ask folks to consider. The pieces that Kelly had just brought up, I feel are some of the values of which we want to move forward. And part of that is recommendations, acknowledging that we need to uphold, what we're putting forward, whether it is indeed clear anti-racism framework, or is it upholding the status quo? And then the recommendation was, I believe, I saw it in the chat pop up. I apologize. There was a proposed piece that said agricultural workers, BIPOC communities, self-identified with a focus on AI and AN populations. Black population, Hispanic, Latino, Pacific Islander. There was also earlier proposed that food processors, those in the agricultural food industry, be put in that. I also heard Oregon transplant or / chronic conditions, folks with higher levels of chronic conditions, and then urban Native community.
I had also put something in as a recommendation.
Thank you, please, and go ahead and state that one more time for us, Ruth.
That is, we're recognizing the senior population. There are low-income senior housing properties that have under age 65 plus, and other congregate senior living settings where you've got under 65 plus. So I would like to see those environments, people living in those environments that are under 65 plus residing with older people, to also be included.
So multi-generational.
Yes.
And particularly the low-income senior housing.
I would like to say, sorry about that. I absolutely agree about agricultural workers, food processors, and the disproportionate impact. And there are other frontline workers who, again, hourly workers who have had to go to work every day and can't work from home, that, you know, need to also be considered in this. It's hard when you start differentiating between industries. And what I would like to do is talk about all of these frontline workers and then look at it from an operational standpoint to make sure that we're implementing it in a way that addresses the systemic racism that we all agree has hindered our ability to deliver quality health care in our state for some time.
Just a quick question. So is
Yeah.
in cut where it says eligible for vaccine in custody in the second bullet, so does that include everybody that's in prison and jail? I'm not quite sure what that means. Eligible for vaccine in custody.
Yeah, George,
this 16 and up. So eligible based on
okay, fine. But I was asking about in custody. Does in custody mean anybody that's in the state hospital or prison or jail? Is that what it means? Okay, great. Thank you. That's fine.
And jails.
Yeah, fine. Thanks.
I'd like to offer a recommendation to expand the terminology of agriculture worker. We have cultural, indigenous, food gatherers, traditional we have hunters, we have fishers, we have farmers, we have folks in our community that prepare food for our community members. We have indigenous food sovereignty initiatives and efforts that have been implemented in response to the social and economic impacts of COVID, because the food system is flexible to meet our needs related to food insecurity as a growing crisis during this time of this pandemic. And I also think in terms of teachers, expanding that to what Deborah Whitefoot had mentioned last week, our traditional cultural language keepers and our cultural carriers.
Hi, New. I want to make a comment and also a question. I guess right now, current data nationally and statewide, the people that are being vaccinated are white people right now. So the current guidelines that we have so far laid out nationally and statewide, they focus more on white people. So right away, that's a big disparity already. So I think this is really essential that we, before 12 o'clock, hopefully, can make a motion to have a recommendation to move forward on what we discussed, because I'm really concerned that we will move forward. And again, urgency is really important. I think right now with the governor, and I'm sure with OHA and everybody else. So to me, the data that was shared earlier by Dr. Sidlinger basically tells us everything in terms of what we need to know. And so right now, it's really not working for people of color right now in terms of vaccinations, statewide or nationally. So we need to address that really quickly. So I recommend that we move hopefully sooner than later on this motion before we leave the meeting today at 12 o'clock.
Yep.
Thank you, Marin. So is your motion to focus then back to the data for Oregon for, say that one more time for me. I want to make sure I get your words and.
Well, the motion or the recommendation in terms of, I think, and I agree with some of the people in terms of working with focusing on agricultural, food processing, essential workers, and BIPOC communities. To me, that sums it all in terms of the focus. Again, that's sort of my opinion, but unless people have a different way of writing the motion, but to me, that's the focus right now in terms of moving forward as a recommendation.
Maureen, are you suggesting that those so that's the motion is to include those in 1B?
Correct.
So that we can open it right up?
Correct.
Yes.
I just have one, I totally agree with that. I would just ask that recommend that when we put BIPOC communities, that we should focus on the 4 specific communities that are truly disproportionately affected based on the data, which is, I put that in the chat, just to kind of knowing that we have a limited amount of vaccines, that we should target it on those actually most disproportionately affected.
And are those consistent with the communities that were targeted for testing? Would that be the same?
Well, from what I understand, the community, yes, except for what, at least from what I've seen, the communities that were targeted for testing were general BIPOC. And at the time, I don't think we had the data that we have now,
Okay.
that we now see that the disproportionately affecting those 4 specific populations based on OHA's data and CDC's data.
Yeah, that's a good approach. I think that sounds
All
good.
right, this is Jamila. I'm trying to frantically multitask. Could you name those communities so I can type them?
Yeah. The Black and African American population, Hispanic, Latino, Latinx, Pacific Islander, and Alaskan Native, Native American, Indian population.
Can I just add, for example, the Oregon Slavic community, which is like the second largest identifiable cultural language minority, has had the rates of COVID very comparable to BIPOC communities. At the same time, they have an extreme vaccine resistance. And so the thing I, wanted to mention is one of our greatest questions around centering equity is, although it's really great that we're going to prioritize these communities as the next stage, we know the vaccines won't be there in time, barely enough for the prior group. We really need to focus on how to get the communities that have been impacted by these various forces that led them to many other negative health outcomes, to see how to get these vaccines, how to get them to take these vaccines, both through distribution challenges and through hesitancy challenges. So that's going to be the most relevant in the immediate term in terms of equity until more vaccines are available.
Thank you, Zhenya. And I believe we're also going to talk about vaccine hesitancy in Tuesday's meeting as well, to address some of those concerns and how you all can partner with folks. I know there was a couple mentions in the chat regarding whether we can include refugee communities within this group, this next group of folks as well. I want to pause for a second, and thank you, Jamila, for putting together these notes for us. This particular list here is getting larger and larger, right? And so we also know and understand that with not knowing exactly how much vaccine is coming into the state, how do folks want to proceed with the motion of focusing on agricultural, food processing, and BIPOC specific communities there, and other communities at risk for 1B? And that includes adults in custody, ? There.
I just think that other communities at risk needs to be, that's everybody. I mean, so that can't be a catch-all phrase. We have to come up with some way of better defining what that is.
Okay.
And I would agree with the refugee community and the ones that were sort of mentioned, and as well as the incarcerated, because whether they're included by governor's order or not seems to be an open question already. So we might as well reinforce that with this.
And do we have a better terminology or better wording that we want to offer if we want to take that particular piece out? I'm throwing that out to the group.
I think I heard that differently, that the issue is that this is so broad that it's really everybody that's been discussed. So it's not necessarily a verbiage issue, but a grouping issue. That's how I heard it. And if that's not correct, then I need to understand what we actually mean by BIPOC communities, because I don't think I understand if this language is what was to roll out in the next, OHA of who's going to be included. I wouldn't know what that means as far as, so if I'm African American or Hispanic, does that mean I'm already included? Because it says communities. Are we really saying individuals? I'm a little confused at this motion.
Thank you, Kristen.
I think we should remove communities at risk and maybe add those in the refugees community. So it's like individuals who identify as those highest risk BIPOC communities, and those who are refugee or who are refugees, but not everybody at risk.
And no, if I can, I just want to maybe do some kind of clarifying that might help us hopefully narrow it
Please.
down.
Thanks.
So what I'm hearing in the conversation is that those three categories up top, that folks do feel like those are important, and we can, operationally define, or there's been conversations about which chronic conditions, including immunosuppressed, so there's that adults and youth in custody are important because of the outbreaks and the demographics of who's in there. So I've heard that as well as frontline workers. And I know we can talk about what frontline workers are. So I think in one sense, if we could get a general, if I'm capturing this right, head nod from folks that these groups are important to be before general population. I think that's one kind of level of decision making. And then the next is, how do we define, and maybe maybe this group wants to prioritize them and say, these type of workers or these chronic conditions or whatever. But for me, it would be helpful. And I just want to make sure I'm hearing this right, that folks, there has been conversations along with within these groups that these are not the best proxies for race and structural racism. So I guess I would add to this BIPOC folks that are overrepresented in all of these areas. That's generally been where I've heard the conversation and general consensus that these groups are more important based on, not more important, scratch that from the record. These groups should be prioritized based on the data before we get to general population. How does that land with folks?
But I think there's also a motion that before these groups or simultaneously with these groups, people who self-identify as those highest risk BIPOC communities, whether or not they have a chronic condition or anything, would be prioritized.
Yeah, and I think that's what I'm kind of going of, like, here's an overarching, like, yes, we generally consent that this is, that these folks, based on the data, and then kind of getting to, there's motions that I think are going to specify and narrow that in. But I'm just wanting to get a sense if at the end of today, if for these kind of overarching groups, if that's where folks are saying, yes, based on the data we've seen, based on our lived experience, based on whatever, that these are groups that we need to think about before general population. And then we need to do some more narrowing down with these groups about what do we mean. And I would add BIPOC to that. Thank you.
That's what I wanted to make sure that was not, yeah, okay, great.
Yeah.
Rachel, I'm also seeing in the comments.
Rachel,
go ahead.
Sorry about that. Sorry, I keep jumping in. I want to just add a bit more contextualization to that for language, Rachel, that another framing is BIPOC, beyond BIPOC or in addition to BIPOC, is historically underserved as well, historically not prioritized, historically invisibilized, and not included in the policies, practices, and procedures historically. And this is our opportunity to counter that, right? Thanks.
Kelly, could you please repeat what you said after historically invisibilized?
Sure, that, that this is an opportunity to challenge these old ways, these lasting impacts of colonization, which also includes racism. And, we're doing this for transformation so that we create socially just systems that center on the needs of those who are furthest from the resources and access to those resources.
I want to support Dr. Gonzalez's, adding that definition, because I think that a lot of folks don't understand why BIPOC need to be prioritized. So this is a opportunity for education and transformation for us to actually show this is why this group needs to be prioritized. Thanks.
I'm at the point, I think, where I'm going to ask that folks we're going to do a quick kind of consensus feeler, if you will, about what has been proposed. The piece that Jamila is typing up right now is the piece that I would like for us to kind of get a sense from this particular, from the VAC. Where are we at? And you can vote basically by saying 5 is a complete yes, I'm with what is being stated there. 4 sounds good. 3, I guess I'm okay with it. Or 2, anything 2, 1, or a fifth would be no way. So 2 would be I have reservations, but I could be convinced. So what I would like to see is that I know that not everybody has had an opportunity to voice questions or ask more or probe more from colleagues. So if we can just take a second here to think about those first 4 bullets that are on the screen right now. Individuals not covered in the previous group. So this is the group that we're going to recommend move forward as the next part of sequencing. Okay, so it'd be adults 16 to 64 with chronic conditions, adults and youth eligible for vaccine in custody, frontline workers, and then add the BIPOC, historically underserved, historically not prioritized, historically invisible. All those pieces there. So if I could get folks to either we'll put 5 again, love it. 4 sounds good. 3, I guess I'm okay with it. 1, I have reservations. 2, I have reservations, but I could be convinced. 1, hold on, we need to talk more about this. And a fifth would be a no way. So I'm going to ask that you go ahead and hold up that number or fist, if you will, if that's okay with folks, because then we can get a quick visual from everyone.
People are putting it in chat. You want us to hold it up or
okay,
put it
that's
in chat?
fine. In chat, it's fine.
Can't see everyone with.
Yeah.
Okay.
Yeah. Do you want to pull down the share screen so that you can see everybody?
Can I just ask a question on Nui?
Yes, please.
Yeah, so I know that I'm agree with the product, I think, but can the BIPOC go on the top and the rest on the bottom? I just feel that being on the bottom just is not prioritized.
Is on the bottom.
Yeah, we can do that. Thank you, Maria. That's fine. And what I want to do by doing this in this consensus fashion is recognize that we want to make sure folks have the opportunity to ask the questions of the group, right? And so anything below a 3, we're going to need to address before the VAC in a consensus motion can move forward, if that makes sense. So what I'd like to do is in the chat, you can see where folks have landed. And so thank you for putting that in the chat. So I would also give opportunity for folks with anything less than a 3 to ask the questions or probe some more. Okay, so I know we have a few more minutes to get to this. And so I will ask that Kristen and Jenya, if you want to ask questions or probe some more about what this all means, please. Kristen?
I'm sorry to be on repeat. I still don't understand whether it's in this group's purview or whether it is the governor's request or decision as to whether or not prisoners are included in that group. Because personally, I think we're missing that group of multi-generational homes, and that those are the folks that are going to the grocery stores. Those are the folks that are living in these different circumstances with a lot of people in the household that have not been considered in these groups yet. So that gives me some angst.
Thank you.
I can share just briefly that there has been conversation through a settlement that AICs, adults in custody, will be prioritized. So it's a both and in 1B, and the VAC will talk through the sequencing there. So it's both. Yes, the conversation is within the VAC's purview.
Jenya?
Yes, so as someone who was at a vaccine site yesterday and observing what's happening, I'm trying to figure out how this recommendation could realistically be put in place when there's a vaccine shortage and there's a rule that anybody who identifies as BIPOC is I might be missing something, but I am not understanding how that is practical. How are people going to prove that they're a member of the community? How is this how could this actually be operationalized? Because we're talking about an actual plan to save lives.
I have a comment. Again, I know we're running up against time, but I think in lieu of time, in terms of what we wrote, and I think, operational wise, once you have a recommendation, we're in an urgent situation right now. We need to move forward. And right now, honestly, what I've heard, a lot of white people are getting vaccinated that don't meet our young people, not sick, upperly mobile. And so there's really disparities there. And people are not asking a lot of questions through verification. So I think if you're a person of color, it's very obvious, but also in terms of the frontline workers, also can be very obvious. So I really want to wish to move forward on this motion before we leave, if possible. And again, I'm just trying to make sure that we get our work done because I know time is really of essence. And I don't want to wait another week to have more talk and to make another recommendation at that point later in time.
Yes.
And I will add that the operational piece, we are going to have, whatever recommendation comes out, we're going to have to take that and run that through operations. We're going to have to take it through a legal analysis. So if the group can come to that, that is something that we would do and can bring back to you all next week.
I also want to ask Sean to ask anything because you were at a 2. And so again.
Yeah, my only comments are, I agree with the comment that was made about moving or reordering it with the BIPOC community at the top of the list seems fine and appropriate, but I did have a sort of a concern about trying to add all of that definitional language in there beyond just saying this is the group that's been identified for the priority list, because while I don't disagree with the sentiment of the statement, we have not made justification. There are no justifications for all the other bits and parts and pieces that are moving forward. And I'm not sure that I think that the education piece is separate from the list, just like the operationalization of the plan once the list is made is separate. All of those are components that get figured out later. So my preference would be to move forward with the list, but without the additional language supporting why that one particular category is moved up to there.
Can you tell us how many people, what the numbers are? Because I can see people's faces and they're ready to respond to Sean, and we got 7 minutes and I can't stay past 12.
I just want to add that if the recommendation were to include multi-generational, that would alleviate my concerns. And I agree, Maren, on everything you said about needing to make decisions.
So what I hear is that we'd like to add multi-generational into this group and rework the language around including BIPOC, not taking it out, but reworking the wording around that. Is that?
You can send it to us.
Just stating BIPOC without having to do a justification that could be in a bullet someplace later.
Yeah.
But intergenerational, BIPOC and intergenerational, to my mind, go hand in hand.
So what we're gonna go through it one more time, if that's all right with folks. We're gonna leave BIPOC as it is, without. Well, we won't take out the historical pieces. We'll take that piece out right now, and then we're going to just leave it as BIPOC.
Yes.
I would also, what I said before is I think we do have to highlight the communities within BIPOC that are most
so specific.
impacted.
So the 4 specific ones that were pulled out via Safina's comments.
The justification is also, and I'll just be explicit, these are the populations that experience racism every day. And that's why we are needing to also include the justification so that that doesn't get buried.
Thank you.
I think it could be asterisk or something, and
Yeah, it can just be a bullet point or asterisk.
yes,
Yeah.
How is that landing with folks?
yes.
Okay, so we have BIPOC with specific for pulled out, and then the definition or the additional verbiage will be included as an asterisk so that folks understand what it is that we're talking about. Those were those additional ones, and then with the addition of multi-generational homes that we want
I'd
to.
like to add the low-income senior housing that has under 65 plus in it.
No, excuse me. I also want to not get lost in there the distinction between tribal communities and urban-based natives.
Okay, so we put that in there. To Ruth's point about low-income folks with a specific age, I thought you said, Ruth, my apologies.
It's congregate senior living that includes low income, people under 65 that are living in those environments.
Okay. Okay, so I'm going to pause here and I'm going to ask us to vote one more time. So how does this land with you folks? 3, I guess I'm okay with it. 4, sounds good. 5, love it. 2, I have reservations, but I could be convinced. 1, hold on, we need to talk more. Fist is no way, or 0.
No, did we write refugee in the earlier, or are we not writing that?
That was not included in this particular group.
I have a question about refugee.
So,
if we use the term refugee, does that mean they have to show their INS card to prove that they are a refugee?
I don't know that we're, thank you. I don't know that we're going into that specific detail right now.
That's why I'm
Christine.
saying that if you identify them ethnically, then we limit how to
I'm sensing
justify.
I'm sensing, is there a concern that anyone has that BIPOC does not capture certain refugee communities?
Well, absolutely. For example, the Slavic community, which is largely a refugee community, is white. It's been classified as a community of color by the Oregon Coalition for the Community of Colors based on the disparities, but it's actually a white community.
Thank you, Zhenya.
So I think including the Slavic community in that's definitely based on the data. We do see disparities in COVID infections and hospitalization as well as other health conditions.
So I'm hearing that we would like to also put refugee in within this definition today. So I'm going to again ask that we pause, and I'm going to stop with adding more specifics to this piece, and ask that folks go ahead and let us know where we're at so that we can make this recommendation and move forward.
No, I do have a key question. Is there an implied priority in this list or not?
At this point, we are not prioritizing anything in this list.
Okay.
This is moving forward.
No, I'd like to make a clarification.
Yes, please.
It's low income senior housing and other senior congregate living that have people under the age of 65.
Okay.
So it's low income senior housing and other congregate senior housing with people under 65.
Thank you. And right now I'm looking really fast at the chat to see if there was anyone who landed lower than a 3. Because if that's the case, then I don't believe we can say that we can move forward in a consensus model that we're using right now.
I don't see any, sorry.
Mill, you forgot the I for indigenous. That's the word in BIPOC.
Okay.
Apologies.
A 3 is now in the chat. I'm sorry. I don't know if we said below a 3 or
no, below a 3. 3 is I can live with it.
Yeah,
yes.
I can live with it.
And thank you. Can folks help me look real quick? quick. I want to make sure that anybody, because of the consensus model.
Yeah, no, there's just 1, 3.
Okay.
The
Then we're,
else is a 4 or 5.
so yeah, anything below a 3 is where we want to make sure we address that. And so I'm going to, we are at the 12 o'clock hour. I am going to, because we do not have a chairperson for this committee, I would like to ask folks how you would like to go forward in putting this recommendation to folks at OHA. Does one or two of individuals would like to take this and forward it and ask on behalf of the VAC, or how would you like to proceed with that?
And if it streamlines things and people just want to say OHA's on the call, just listen to what we said. We don't have to figure that out. We can
Yeah, I'd rather do that.
Let's look for
We're
that.
here. We'll
We vote
accept
for
it.
that.
We'll take
Okay.
it. We'll operationalize it. We'll come back the next meeting and talk about what are some of the considerations that we need to move through and the things that you all talked about. We'll get you background information on Tuesday, and then we'll come back to this on Thursday. How does that sound?
Thank
I
you,
think that's
Rachel.
great.
Sounds great. I would just, this is Leslie. I would just please encourage OHA when you put the summary of this out to please include the descriptions that were discussed today,
Yes.
particularly around the BIPOC community as a community that was left out of the OHA initial infographics. I can tell you we are continuing to see people turned away because they're not included on an OHA graphic. What you put out in infographics is honestly what is happening on the ground. So please include and please hear the words of people today when they say that we need to include explanations for this and make
Yes.
sure that that makes it into your infographics as well. Thank you.
Yes, thank you. Thank you so much, everyone, for staying the extra couple minutes. Thank you for the hard work and the agreement to move forward as best as we can as a group. I really appreciate the patience you all had with the process today, and we will work through those minutes and notes. And thank you for this recommendation from the VAC. We now hand it over to OHA folks, and we will do all of that. And so our next meeting will be held on Tuesday. I would encourage you as you process some of this information, those things that we will have that we want to discuss on Tuesday will be vaccine distribution, vaccine hesitancy, I believe is also one of the things that we heard from today. And so those two topics for the 1 hour session on Tuesday. More information will be coming to you. And so thank you so much for this really solid 2 hours. Thank you so much. So have a great afternoon, everyone.
Thank you. Bye, everybody.
Thank you. Bye.
Great work. Thank you.
Hi, I have a question. This is Nanette speaking.
Oh, hi, Dee.
The document that Jamila was typing, is that going to be available to us via email immediately after this so we can mull over what was just fresh in our minds as opposed to
Yeah,
having to
we'll
wait
definitely
for
need to
minutes?
tighten up that. Absolutely. We'll tighten it up as the recommendation moving forward with all of the more detailed pieces. We